Well, hello everyone, and welcome to our Zoom webinar, Advancing Liver Care, Common Cutting Edge Therapies for Liver Disease. Thank you so much for joining us here today. My name is Marissa, and I'm the Engagement Coordinator at Global Liver Institute, which is a nonprofit dedicated to empowering patient advocates and advancing liver health. This webinar is part of the Tackling Liver Cancer Disparities series, held in collaboration with the Health Council of South Florida, which I will pass it over to Vicky to introduce herself and her organization.
Hi, good afternoon, everyone. Thank you for joining. My name is Vicky. I'm the regional coordinator for the Southeast Florida Cancer Control Collaborative. Say that 5 times. So the Health Council of South Florida is a trusted regional organization which is dedicated to improving health and wellness in both Miami-Dade and Monroe County. For over 50 years, the HCSF has provided unbiased health data, strategic planning, and community services while fostering collaboration and advocating for equitable healthcare policies. The Southeast Florida Cancer Control Collaborative is a voluntary network of healthcare providers, community organizations, and advocates working together to reduce the burden of cancer across Southeast Florida, and it's supported administratively by the HCSF. SFCCC promotes education, advocacy, and research as well to improve access to cancer care in our region. Thank you once again for joining.
Great, thank you, Vicky. With us here today, we are so honored to have Dr. Shaun Chandna, who is an attending physician at the Olive UCLA Medical Center and associate professor of medicine in the David Geffen School of Medicine at UCLA. Dr. Chandna is a highly experienced hepatologist recognized for his expertise in general and transplant hepatology, as well as his many contributions to liver research and national prevention committees. At the end of this presentation, we will have a couple minutes for Q&A, so feel free to hold your question to the end or put in the chat and we can read it out at the end. With that, I will let you take it over. Thank you so much for being with us here today.
Thank you so much for inviting me to speak. It's an honor to be here. We've got a broad topic and a lot of content here, so we'll try to go through it and answer some questions at the end. Okay, so we're going to talk about advancing liver care, common and cutting edge therapies for liver disease. And this is just an introduction to myself, my disclosures. So let's talk about the global burden of liver disease and cirrhosis. Chronic liver disease causes over 2 million deaths annually, accounting for approximately 4% of all global deaths. Cirrhosis alone is responsible for about 1 million deaths per year, making it the 11th leading cause of death worldwide. The global prevalence of advanced liver fibrosis is 3%, and cirrhosis is about 1% in the general population. These trends are increasing since 2016. We know that the burdens of cirrhosis are shifting, that while viral hepatitis, such as hepatitis B and hepatitis C, do remain a major cause, we know that MASLD, previously known as NAFLD, is now the leading cause of incident cirrhosis globally in both high and low to middle income countries. And the key risk factors for burdens of liver disease and cirrhosis are viral hepatitis, alcohol intake, obesity, diabetes, and there can be some genetic links as well. In terms of liver cancer, this is the third leading cause of cancer death worldwide, with an estimated 900,000 new cases and 800,000 deaths in 2020. The incidence of mortality are the highest in East Asia and Sub-Saharan Africa. HCC typically is in the context of chronic liver disease, often due to hepatitis B, hepatitis C, alcohol, MASLD, MASH, or cirrhosis of really any etiology. The mortality to incidence ratio for liver cancer is close to 1, so there's a poor prognosis and a high lethality, which is important in terms of taking care of these patients and diagnosing and recognizing the disease early. The number of new liver cancer cases is projected to increase by 50%, over 50% by 2040, driven by demographic changes and the rising prevalence of metabolic risk factors. And so we know in terms of key trends that the global burden of disease is increasing. And while standardized death rates for cirrhosis have declined in many regions, the incidence rates are rising, especially for metabolic associated liver disease. Early detection does remain a challenge and contributes to late-stage presentations, which can often hinder recognition and treatment by delaying it. And effective public health strategies must integrate prevention, early detection, and management of both infectious and metabolic liver disease risk factors to curb future morbidity and mortality. Regional disparities do highlight the need for tailored interventions, particularly in low and middle income countries where the burden is rising most rapidly. In terms of the spectrum of liver disease, this can include viral hepatitis, chronic hepatitis B and C, alcohol-associated liver disease, MASLD, autoimmune diseases, hereditary diseases such as alpha-1 antitrypsin, hemochromatosis, Wilson's disease, and drug-induced liver injury as well. And each of these liver diseases does have distinct risk factors, clinical features, and progression patterns. Overlapping etiologies can complicate the diagnosis and requires individualized approaches. And again, as we discussed, late detection often leads to advanced disease and poor outcomes. So it's important to recognize this early. In terms of the spectrum of steatotic liver disease, this includes both MASLD and MASH. MASL meaning 5% hepatocytes having steatosis in the liver, 5% steatosis in the liver, and then MASH being metabolic dysfunction-associated steatohepatitis, which is associated with lobular inflammation and ballooning hepatocytes, and which is the trigger for fibrosis and disease progression. Now, the AASLD had recognized, along with the Delphi consensus in naming steatotic liver disease, that there is a overlap syndrome of MET-ALD. This is MASLD with increased alcohol intake that can vary from being MASLD predominant to ALD predominant, depending on how much weekly alcohol intake is ingested. And so for females and males, for females, about 50 grams per day, and about 60 grams per day for men, which is essentially ALD predominant. So there's a wide spectrum of variation. It's important to recognize that patients can have MASLD or ALD or MET-ALD. And there are also other causes of steatosis as well, such as drug-induced liver injury, other certain types of diseases, or even cryptogenic causes. But most cryptogenic causes have been thought primarily to be MASLD and MASH. Now, in terms of the global prevalence of MASLD from 1990 to 2019, this was estimated to be about 30%. And really, this global prevalence is rising, which is very alarming. This was 38% from 2016 to 2019. So very high incidence of MASLD globally and continuing to worsen. If we look at the disease spectrum, this was a nice paper by Dr. Lumba in 2021, looking at the spectrum of 60 to 80 million Americans having MASLD, and a subset, about a quarter, 15 to 20 million having NASH or MASH. But over 20 to 30% over 3 years will have fibrosis progression. And of those, we know that patients can be rapid progressors, that 20% of those patients with advanced fibrosis can develop cirrhosis over a 2-year period, such that 1 to 2 million people will develop cirrhosis. We know that of those, patients can decompensate. 30 to 40% of those patients will typically die of liver disease. And there's an increased risk of liver cancer, which is also about a rate of 1.5 to 2% per year, which requires biannual screening with abdominal ultrasound and alpha-fetoprotein every 6 months. So it's important to continue HCC screening for cirrhotic patients, and then also to recognize that these patients may be at risk of decompensation, which can drive them further into liver failure and then ultimately the need for liver transplantation, or they may succumb in terms of increased rates of mortality. Now, if we talk about the pathogenesis of how steatohepatitis works, we know that as dietary sugars are ingested, such as fructose particularly, or as the adipose tissue is stressed with inflammation and insulin resistance, free fatty acids in the blood can go into hepatocytes and can be taken up into triglycerides or can be oxidized through the mitochondria, or lipotoxic lipids can undergo endoplasmic reticulum stresses, oxidant stresses, and inflammasome activation. This can then lead to a pro-inflammatory cytokine cascade that leads to hepatic stellate cell activation and leads to fibrosis deposition. In terms of the care pathways for MASLD, it's important to recognize in the primary care setting that we should use a FIB4 screening as the initial tool. The FIB4 cutoff is 1.3, which can recognize that patients are indeterminate for advanced fibrosis, and FIB4 over 2.67 is very high risk for advanced fibrosis. These patients need to have a secondary assessment, typically a vibration-controlled transelastography, which commercially, there are different vendors. FibroScan is one of them, but there are other vendors as well, or an enhanced liver fibrosis test. And so if patients are determined to be low risk using VCT or ELF, they can go back to doing a FIB4 periodically in the primary care setting. The frequency dependent on if they have diabetes, prediabetes, or metabolic risk factors, as you can see here on the left-hand side. And on the other hand, if those patients have a potential for moderate to advanced fibrosis or advanced fibrosis or cirrhosis, those patients need to be referred to a gastroenterologist, hepatologist for additional stratification, and liver biopsy is becoming less common, but these patients need to have the idea of targeting pharmacotherapy early on. So pharmacotherapy, as we'll talk about, is FDA approved now for stages 2 to 3. And then for those patients that have cirrhosis, they do need cirrhosis-based management, which includes variceal surveillance as well as hepatocellular carcinoma surveillance every 6 months. Now, all patients should undergo a cardiometabolic risk reduction with preferential use of medications that have an NAFLD benefit if possible, need assessment of alcohol intake and ideally abstinence, and then lifestyle management. So I just want to highlight the AGA clinical care pathway here, which says that if patients are low risk that have a FIB-4 less than 1.3, or let's say they had a FIB-4 over 1.3, but they're determined by liver stiffness score to have less than 8 kilopascals, which is less than the cutoff for significant fibrosis, those patients do need lifestyle interventions and weight loss. They need cardiovascular risk reduction. We know that many of these patients with MASLD MASH, the leading cause of mortality is actually cardiovascular disease. And then they do need standard of care for their diabetes. For those patients, on the other hand, that are found to have moderate to advanced fibrosis, they need the same interventions with targeted pharmacotherapy. The only thing I'll note here is that for high-risk patients, as we talked about, they do need also this lifestyle intervention, encouragement of weight loss. I typically would recommend about 10% weight loss for all of my patients with MASLD. We know that about 3% weight loss can cause steatosis reduction. At 7%, it can improve steatohepatitis, and at 10%, it can potentially improve fibrosis. And so it's important to counsel your patients on weight loss and then using a hypocaloric diet, which often the Mediterranean diet is being recommended now, but typically higher in protein and less in carbs and less in fats. So in terms of pharmacotherapy for high-risk patients, there is no FDA-approved pharmacotherapy for patients with cirrhosis right now. Of course, patients may be eligible if they for a GLP-1 if they have obesity and other comorbidities, but there is no targeted pharmacotherapy for MASLD MASH that is approved right now for those patients that have cirrhosis. And cardiovascular risk reduction and management of metabolic comorbidities is important for all of these patients. So in terms of talking about MASH stage 2 to 3 fibrosis, FDA-approved therapies, we'll talk about this phase 3 study of resmetirom in NASH or MASH with liver fibrosis. And this essentially is a thyroid hormone receptor beta selective agonist, which targets the THR beta nuclear receptor in the liver, and showed in the primary endpoint that there was an improvement of fibrosis by 1 stage without worsening of steatohepatitis in 25.9% in the 100 milligram arm and 24% in the 80 milligram arm, as opposed to 14% in placebo. Further, if you look at the left-hand side in terms of resolution of steatohepatitis without worsening of fibrosis, there was a differential of nearly 20% at about 30% in the 100 milligram arm versus 10% in the placebo arm, and then 26% in the 80 milligram arm. And more recently, in the Essence trial, semaglutide recently was approved as well at 2.4 milligram dosing, which also showed rates of improvement. I will have you note that the numbers look fairly wide here. So semaglutide had a differential rate of 28.7% in terms of resolution of steatohepatitis, and for fibrosis, 14.4%. This data was imputed for missing values, and the previous data for resmetirom was not imputed and had an independent sensitivity analysis that was conducted by the FDA afterwards. But very similar rates overall of steatohepatitis and fibrosis improvement. So these are potential options. Now, in terms of patient selection for stage 2 to 3 fibrosis for resmetirom, the AASLD has a very nice guidance. I won't go through all of this laboriously, but patients should be assessed for response at 52 weeks. And in terms of who to consider, you're essentially considering patients that have moderate to advanced fibrosis as determined by VCTE or MR elastography, or potentially liver histology if a biopsy was done, although that's becoming less common nowadays. It's not recommended for patients that have cirrhosis, particularly those with a VCTE over 20 kilopascals or an MR elastography over 5, or for those that have concurrent active liver disease of another etiology, those that have excessive alcohol use, or those that have active thyroid disease. And there is a gray zone where patients can be determined to be potentially candidates if they're kind of in the gray zone, but this should be done with centers of expertise or with providers of expertise in liver disease. So the response rate is at the decision point of 52 weeks to reevaluate by VCTE primarily or MRE, and to look for reductions in elastography, in liver stiffness measurements, and then also ALT reduction. So primarily for VCT, we're looking for at least a 25% improvement. If patients have worsening ALT and worsening VCTE at 1 year, they should stop. They should essentially stop therapy if they have worsening of their non-invasive tests. However, if they're in the gray zone and they have a subthreshold improvement with no evidence of progression, then it's up to the provider at that time to determine whether or not they're going to continue or discontinue therapy. So treatment monitoring is done at 3 months, 6 months, and 12 months. And of course, at baseline, typically looking for a hepatic panel, thyroid function panel, and lipid profile. And then again, reassessing for stiffness at 52 weeks. Now, in terms of semaglutide, the AASLD also released a guidance statement that looks at this as well. And again, determined indications being moderate to advanced fibrosis, potentially also using enhanced liver fibrosis testing, which can also be used for resmetirom indication as well, or liver histology. And then again, similar things with regards to not recommended in patients with cirrhosis or another concurrent active liver disease, or for GLP-1 in this case, also in pregnancy, personal or family history of medullary thyroid carcinoma, or patients with MEN2. I will say there's no data also in pregnancy for resmetirom either, so it should be avoided in that cohort as well. And then again, there is a gray zone, but the decision point here is to evaluate for response at 72 weeks, using a little bit of different thresholds for liver stiffness measurement improvement of about 30%, and very similar to semaglutide in terms of looking at the response rate and seeing, are these patients improving to continue therapy at 72 weeks? On the other hand, if they're not improving, to discontinue therapy. And if they're in the gray zone where they're not necessarily improving or worsening, then to kind of have the individualized decision of continuing therapy or not. So there is also recommendations for treatment monitoring from the AASLD, which is here. And you can see that there's this importance of screening for suicidal thoughts, and then also evaluating for thyroid nodules potentially, and then retinal exam if diabetic. On treatment monitoring is clinically indicated, and then again, evaluating 72 weeks for response rate. Now, moving on to chronic hepatitis B, we know that this affects 258 million people worldwide. It's a major cause of HCC and cirrhosis. It's a high prevalence, over 8% in high regions, and intermediate regions are less than 2 to 7%. And then there are low risk regions of less than 2%. In the United States, most of these cases do occur from immigrating from endemic regions or those with high risk exposures. Perinatal transmission, we know, remains the most important route in endemic areas, with 90% of infected newborns developing chronic infection. And the risk of chronicity does decrease with age, such that it's 25 to 30% in children less than 5 or less than 5% in adults. This is kind of a global prevalence map showing you very high rates in sub-Saharan Africa, parts of Asia, such as Mongolia. And then looking at the cascade of how hepatitis B works, we know that hepatitis B can enter into the hepatocyte and randomly can integrate into host DNA, but also form cccDNA, which allows for transcription and formation of core and capsid, core assembly and capsid formation, and ultimately reverse transcriptase, and leads to a DNA synthesized virus, which is exocytosed. Now, in terms of the AASLD guidance, there are different hepatitis B phases, such as immune tolerance, immune active, e antigen positive, immune active, e antigen negative, inactive chronic hep B, and indeterminate phases. And it's important to recognize these phases. So immune tolerance is typically that which has a normal ALT, which is e antigen positive, which has a high viral load, typically over 10 million. On the other hand, if patients have hepatitis B e antigen positive and they're immune active, they will typically have an ALT of at least 2 times normal and a DNA level over 20,000. If they're immune active but e antigen negative, they usually have an ALT over 2 times normal with a DNA level over 2,000. And they are inactive chronic hepatitis B, or what we used to call chronic carriers. Those patients are e antigen negative with a low DNA of less than 2,000 and an ALT that's normal. And then there are indeterminate phases where patients are in a gray zone. So this is kind of a nice graphic that shows you immune tolerance, that you have a normal ALT with very high viral load levels of DNA. On the other hand, there's an immune clearance phase, which is the immune active e antigen positive phase, where you do have high viral loads and also have an elevated ALT. And usually you typically want to consider treatment in this time point, or the inactive carrier state, where you're e antigen positive with a normal ALT and a low DNA level, or in the sense of having e antigen negative immune active phase. This says reactivation, but should be e antigen negative hepatitis immune active phase, which has a high ALT, typically over 2 times normal, and then a DNA threshold over 2,000. Typically, these patients are considered to be patients you want to treat because they have active inflammation, they have risk of fibrosis progression. Same with the e antigen positive immune active phase as well. And then there are other patients that may have resolved or even potentially occult infection. So I won't go through all of this in great detail, but the AASLD guidance has released new guidance on chronic hepatitis B and really goes through very well if patients are surface antigen positive without cirrhosis, and they're e antigen positive, what are the treatment thresholds? So typically, if they're immune tolerant, you want to continue to monitor them progressively. You may consider therapy if patients have stage 2 fibrosis or if they're over 40 years old. On the other hand, if their immune active phase, such as their ALT is over 2 times normal and their DNA is over 20,000, you do want to treat those patients with antiviral therapy. And then if they are indeterminate, then you want to consider monitoring them closely, assess for fibrosis. Again, you may consider therapy if those patients are having stage 2 fibrosis or higher or have an age over 40. And then for those patients that do not have cirrhosis that are e antigen negative, that are surface antigen positive chronic hepatitis B, as we discussed, if they're in the immune active phase with an ALT of 2 times normal and a DNA level above 2,000, you do want to treat those patients. On the other hand, if they're kind of in this inactive chronic carrier phase, DNA level less than 2,000, ALT less than the upper limit normal, you want to continue to monitor those patients. And then if they're in the indeterminate phases, you want to, again, closely monitor them. If they're in the indeterminate phase with a high DNA level, you may want to consider shared decision-making and treatment in those patients that are at increased risk of liver cancer. And then for all patients who are cirrhotic, whether compensated or decompensated, it's important to treat these patients with antiviral therapy. For patients that have liver cancer, it's important to treat those patients with antiviral therapy. If patients are having a suboptimal response, the provider may consider switching antiviral therapy or may consider adding antiviral therapy, in which case it's important to monitor the DNA level closely until it's undetectable and then expand it out afterwards. And then for those patients with decompensated disease, it's important to consider transplantation and referral early. So in pregnant patients, previously, we would only consider using tenofovir disoproxil because it was category B. We know that there is data now for tenofovir alafenamide, so TDF or TAF can be started at 28 weeks for patients that do meet the threshold, which is a DNA level over 200,000. And typically at delivery, this antiviral therapy can be stopped, TDF, TAF. If it was only for essentially maternal to child transmission prevention. But it's important to monitor post-delivery to make sure there's no withdrawal flares. Now, if patients met the indications already for chronic hepatitis B therapy on antiviral, then they should just continue therapy. And then for infants to get hepatitis B immunoglobulin and hepatitis B vaccination within 12 hours, and then also to retest them for chronic hepatitis B at 9 to 12 months. So in terms of preventing horizontal transmission, we want to consider vaccination in susceptible and high-risk patients, consider universal screening, especially those that were potentially exposed. There are other scenarios when antivirals may be used in high-risk scenarios. And then counseling is important to explain transmission routes to patients, to avoid stigmatization, and to have shared decision-making as well. In terms of potential future agents, this is just to highlight an NEJM article out of a phase 2 trial, phase 2b multinational randomized trial that was unblinded, but this is looking at bepirovirsen, and just on the bottom to see that there were 9 to 10% rates of S antigen loss and DNA below the lower limit of quantification. So that's quite remarkable actually to have S antigen loss because most people with chronic hepatitis B do not, convert to S antigen loss. It's very low rates. And then looking at beloveritide, it's a phase 3 randomized trial in chronic hepatitis D. And this is an antiviral drug that blocks entry of HDV into the hepatocyte. We can see here that there was improvement in HDV RNA levels and normalization of ALT improvement. And then looking at the combined response at 48 weeks, there was a significant differential in percentage of those patients that responded at 48% in the 10 milligram group as opposed to 2% in the control group. So there is good viral suppression here in chronic hepatitis D, which chronic hepatitis D or delta is essentially occurs with co-infection with hepatitis B. And so it's important to screen for your patients that have chronic hepatitis B for delta virus. This is approved in Europe. It's not approved in the United States as of yet. In terms of moving on to chronic hepatitis C, so we know that 70 million people are infected worldwide. There's up to 2 million new infections annually. Chronic infection develops in about 70% of acute cases, and 20% progress to cirrhosis over 20 to 30 years. The annual mortality is about 400,000 deaths from cirrhosis and liver cancer. And in the United States, the highest prevalence is in persons that were born in the baby boomer cohort from 1945 to 1965, also in those who inject drugs and incarcerated individuals. There are very good goals for elimination targets by 2030, but as of right now, we're underdiagnosed and undertreated globally. HCV is an RNA virus that's transmitted by blood-to-blood contact. It primarily infects hepatocytes. Chronic infection, as we discussed, occurs in about 70% of cases, and this can lead to fibrosis progression and the risk of cirrhosis. And there are 6 major genotypes, with genotype 1 being the most common in the United States. So universal screening is recommended for all adults that are 18 years or older, and then also for pregnant women at each pregnancy. And typically we screen for patients with an HCV antibody, but if it's positive, we can do a confirmatory test for HCV RNA, which needs to be done to look for active virus. And reflex RNA testing is recommended. I think many labs have an automatic HCV antibody reflex that once it's positive, it will go to HCV RNA testing. So genotype testing is no longer required before treatment with pan-genotypic direct-acting antivirals. Then we also need to assess for fibrosis stage in these patients to make sure that we're not missing advanced fibrosis or cirrhosis. So that can commonly be done with a FIB4 test and sometimes elastography, and much less commonly biopsy. So this is just a schematic to show you that hepatitis C has uptake, fusion with into the hepatocyte, release of essentially viral particles that lead to translation, ultimately replication, assembly, and release. And then depending on which direct-acting antivirals we're using, such as NS5A inhibitors, those can affect assembly and replication, NS5B inhibitors affecting genome replication, or NS3 inhibitors affecting polyprotein processing. And these are all common direct-acting antiviral therapies that we're using now. So treatment-naive patients without cirrhosis is from the AASLD-IDSA guidance. It's important to make sure that your patients do not have cirrhosis. A FIB4 over 3.25 would be high risk, and elastography over 12.5 kilopascals would be high risk for cirrhosis. There are other non-invasive tests that can be used as well. Of course, it's important to look at the imaging, make sure they don't have a nodular liver, splenomegaly, platelet count of less than 150,000, or if you had access to a prior liver biopsy showing cirrhosis. You really want to make sure your patients do not have cirrhosis when they're following this treatment pathway, which essentially is assessing their biochemistries, assessing for drug-drug interactions, ruling out co-infection with hepatitis B and HIV. And then ultimately, we're looking for post-treatment assessment of cure, which is HCV RNA testing 12 weeks following the completion of therapy to look for sustained virologic response. So if cure is achieved and they're non-cirrhotic, no additional follow-up is recommended. But if it's not achieved, then there are potential therapies that can be used for those that have relapsed. Now, glecopir preventosvir is given as 8 weeks with food. On the other hand, sofosbuvir velpatasvir is given at 12 weeks without food. So fairly high cure rates, excellent rates, really in the very high 90 percentile. On the other hand, if your patients have cirrhosis, really the main focus here is that these patients need to continue to have cirrhosis care. So that means their liver cancer screening, as we've discussed, with ultrasound and alpha-fetoprotein every 6 months, evaluating for variceal screening. And then patients that are decompensated should not be treated with this pathway, but those that have compensated cirrhosis can be treated with essentially these direct-acting antiviral therapies, the same glecopir preventosvir for 8 weeks. On the other hand, sofosbuvir and velpatasvir for 12 weeks. However, if patients have compensated cirrhosis and they're genotype 3, and sofosbuvir velpatasvir is being considered for use, then you have to make sure that those patients do not have a Y93H mutation. So NS5A testing would have to be done in order to determine that, which is a bit complicated and not routinely, ordered right now. But it is important to note that. And just to go back to this, it's important also not to use protease inhibitor therapy, which glecopir preventosvir is within that realm for patients that have decompensated cirrhosis, because protease inhibitors previously were linked to increased rates of decompensation mortality. So that's why this is recommendation here is for compensated cirrhosis. But I encourage folks to look at the AASLD IDSA guidance, and of course, have your patients referred to an expert gastroenterologist, hepatologist, if you're dealing with patients that have compensated cirrhosis for HCV treatment, which we're not discussing in detail in this presentation. Now, in terms of alcohol-associated liver disease, this has been rising since 2014. This was accelerated by COVID. There are the highest increases in young adults, women and minorities, and alcohol-associated liver disease has a large spectrum that encompasses steatosis, steatohepatitis, fibrosis, cirrhosis, and of course, the risk of HCC. In progression-related risk factors, this can include the quantity and duration of alcohol use, female sex, obesity, genetics, binge drinking, and coexisting liver disease. And most with heavy use will develop steatosis, but only about 10 to 20% will progress to cirrhosis. The highest risk is in those that have alcohol-associated hepatitis, particularly severe alcohol-associated hepatitis. And of course, abstinence is the cornerstone of management. So just to show you, in a healthy liver with 20 to 30% of women who drink excessively, about 5 to 10% of those patients will develop significant fibrosis, and another 5 to 10% of those will develop cirrhosis. On the other hand, of those that have alcohol-associated liver disease with steatosis, about 4 to 8% of those patients may have alcohol-associated hepatitis. In patients that have alcohol-associated hepatitis, those patients have a much higher risk of fibrosis progression, such that nearly a quarter will develop F2 fibrosis, which is stage 2, and nearly a quarter of those will develop cirrhosis. And the risk factors that are associated with continued fibrosis progression, of course, is the amount and duration of alcohol use, as well as binge drinking. And females are at higher risk as well for progression. Now, there are integrated care models. It's important to combine behavioral and pharmacologic therapy for alcohol use disorder, to consider screening tools such as Audit C, motivational interviewing and interventions, and considering adjunct alcohol biomarkers such as phosphatidylethanol testing, PEth testing, or ethyl glucuronide testing to see if patients essentially to help track their alcohol use and to kind of help the clinician in that setting to determine how much consumption there potentially is. In terms of non-invasive fibrosis assessment, again, FIB4 can be used, or transelastography. Liver biopsy is not used very commonly. And it's important to recognize what are the therapies that we can use for alcohol use disorder. And so baclofen has been the most studied. That was recommended by the ACG guidelines. However, really the FDA-approved therapies are naltrexone and acamprosate. So acamprosate needs to be adjusted for renal function. Naltrexone, we typically avoid in decompensated cirrhosis or liver failure due to potential hepatotoxicity risks. Gabapentin and topiramate are also possible options, but have limited evidence. And disulfiram, known as Antabuse, is contraindicated. We don't give that to patients anymore due to significant hepatotoxicity risk can be fatal. So I would say naltrexone and acamprosate are the most commonly used. With benzodiazepines, we need to be very careful giving this to patients with cirrhosis and alcohol-associated liver disease. It can be used, of course, for withdrawal, but it can also precipitate encephalopathy, especially in those patients with advanced liver disease. Now, in terms of alcohol-associated hepatitis, if it's severe, these patients should be hospitalized, and the indication for corticosteroid should be determined based upon their discriminant function if it's over 32, or if their MELD is over 20, meaning a 21 or higher MELD, in the absence of contraindications. Those contraindications include things like infection, pancreatitis, renal failure, GI bleeding. And in terms of moderate alcohol-associated hepatitis, this also has a resulting significant morbidity and mortality, but studies are needed and therapy is not recommended at this time for moderate alcohol-associated hepatitis. I will say in terms of assessing the response, it's important to utilize the Lille score at day 4 or day 7. Ultimately, day 7 is recommended in the guidelines. However, day 4 can also be used to assess for response. And in those that are non-responders, steroid use should be discontinued. Now, the ACG did also come out with this remark about IV N-acetylcysteine being a potential use for corticosteroids. However, this is not endorsed by other societal guidelines and has some conflicting studies. And pentoxifylline is not recommended, as shown in the STOP-AH trial, that it did not result in an improvement in those patients with severe alcohol-associated hepatitis. Nutrition is very important for these patients. They should be getting 1.2 to 1.5 grams per kilogram of protein intake daily, 35 kcal per kilogram per day of nutrition. And so sometimes enteral nutrition needs to be considered, but oral is certainly fine if they can tolerate it. Supplementing them sometimes with folate, thiamine, B12, zinc if they need it. Routine prophylactic antibiotics can be avoided in severe alcohol-associated hepatitis. Now, some patients that have severe cases that are non-responsive may be considered for early transplantation. This needs to be done in an individualized context, and this requires a structured psychosocial assessment. This is also center dependent as well. Sobriety duration should not really be the sole criteria for listing. Every center kind of has a process in place to evaluate these patients. And really see if there's good social support, good family support, some mechanisms for abstinence to continue with support systems afterwards. And so really a multidisciplinary approach is recommended to improve outcomes in this setting. Now, in terms of primary sclerosing cholangitis, we're moving on to a different topic. This is a chronic progressive cholangiopathy that has fibroinflammatory damage of intra and extrahepatic ducts. This has a very strong association with IBD, associated almost 80% of PSC patients have inflammatory bowel disease, most commonly ulcerative colitis. This can affect all ages and both sexes, and it can recur after transplantation. Again, this can also lead to the risk of cirrhosis, decompensation, liver failure, increased risk of cancer, and it's important to survey for that. Right now, there's no proven disease-modifying therapy. So this is diagnosed characteristically by multifocal strictures and beating on an MRI and MRCP. We don't do ERCPs anymore for diagnostic purposes. It's really reserved more for tissue sampling and therapy. It is important to exclude other causes such as IgG4-related disease or biliary obstruction in these patients. Sometimes patients can have small duct PSC, which is much less common, or overlap with autoimmune hepatitis where a liver biopsy needs to be considered. And these patients do have a high risk of having concurrent inflammatory bowel disease with ulcerative colitis. We know that ulcerative colitis also can have an increased risk of colon cancer, significantly higher than the general population. So patients, when they're diagnosed with primary sclerosing cholangitis, do need a colonoscopy with biopsies at diagnosis. Now, there's a markedly increased risk of cholangiocarcinoma. The risk is about 0.5 to 1% annually, and at a 10-year cumulative risk of about 6 to 11%, or at 30 years, about up to 20%. So these patients should undergo an annual MRI, MRCP with CA19-9 for surveillance. In terms of gallbladder cancer, their lifetime risk is 2 to 3%. They do have an increased risk of HCC as well. And then colorectal cancer, of course, with PSC IBD is also higher than an IBD alone. So as we discussed, annual imaging is important with an MRI, MRCP, and CA19-9 for cholangiocarcinoma screening and gallbladder cancer. They're at increased risk of cholangiocarcinoma. For those that have gallbladder polyps over 8 millimeters, a cholecystectomy is recommended. If they have gallbladder polyps less than 8 millimeters, that should be monitored with an ultrasound every 6 months. They should also be undergoing HCC surveillance if they have cirrhosis. For those that have colonoscopy at PSC diagnosis, as we discussed, these patients need to have typically a colonoscopy every 1 to 2 years. I would actually caution and say that this should be annually for those patients that have PSC with IBD. But if they do not have IBD, a colonoscopy considered every 5 years to see if they are developing IBD. And then ERCP can be done with cytology in fish for relevant strictures or those with suspected cholangiocarcinoma. Not to go through this entire schematic, but essentially we're looking for relevant strictures, which used to be called dominant strictures, but relevant strictures are those which are kind of like the tightest strictures that are causing symptoms in the patient, whether it's jaundice or pruritus or other things, or a significant increase in liver tests. And so it's important to do both cytology and fish, which increases the detection and the accuracy to detect cholangiocarcinoma. Now, I will say there are patients with perihilar cholangiocarcinoma that can be considered for transplantation in certain cases. Typically, if the tumor is less than 3 centimeters, there's a very extensive protocol, and there is a pathway for MELD exception from the National Liver Review Board. So that is something that can be considered in select folks who have primary sclerosing cholangitis with a perihilar cholangiocarcinoma. Now, in terms of therapy, there's really no proven modifying disease therapy. We know that ursodiol can be considered in select patients. There's been some recent data and guidance that suggests that this may be considered in those who are not in clinical trials to potentially improve outcomes, that there may be some surrogate markers such as alk phos improvement translating to improve outcomes. However, this is, again, not disease modifying. There's no evidence that UDCA will improve transplant-free survival or reduce cancer risk, but this can be considered at 13 to 23 mg per kg per day. High dose ursodiol is not recommended. It's contraindicated due to increased adverse events and also potential risk of colorectal neoplasia. And so if patients are started on ursodiol, they should only be continued if there's a meaningful alk phos reduction or symptom improvement within about 6 to 12 months. Now, moving on to primary biliary cholangitis, this is a chronic autoimmune cholestatic liver disease that has a progressive destruction of small intrahepatic bile ducts. This predominantly affects women that are age 40 to 70. There is an increasing incidence in men. It's characterized by persistent elevations of alk phos, and this can progress, and also GGT. This can progress to cirrhosis and liver failure. And the symptoms can often include pruritus, fatigue. Patients can have associated syndromes such as Zika syndrome with dry eyes and dry mouth. And this can significantly impact their quality of life, having pruritus and fatigue. So the diagnosis is based upon elevated alk phos that's persistent, a positive anti-mitochondrial antibody, or there's a small proportion of AMA negative patients that can have PBC-specific antibodies, such as anti-SP100, anti-GP210, or liver biopsy showing chronic non-suppurative destructive cholangitis. Now, again, only 2 out of 3 criteria are needed to meet this, so you really do not need a biopsy if your patients are AMA positive and have an elevated alk phos. I will caution, however, that's important to note that the autoimmune markers can sometimes be falsely elevated in those patients who have hepatic steatosis, particularly ANA, smooth muscle, if we're referring more to autoimmune hepatitis. Mitochondrial antibody positivity has, in patients that do not have a formal diagnosis of PBC, previously also had this potential association that patients may be at risk to develop PBC later on. So it's important to kind of caution the positive autoimmune markers. But AMA is positive in 95% of PBC patients. It's highly specific. The liver biopsy is only recommended in AMA negative cases or when overlap with autoimmune hepatitis is suspected. And there can be associated autoimmune conditions such as Sjogren's syndrome, thyroid disease, or potentially celiac disease. Now, the risk of liver cancer is again increased in those that have cirrhosis, and the annual incidence about up to 3 to 4%. And the prognosis does depend upon treatment response to ursodeoxycholic acid. That complete responders have a 5-year transplant survival at 95%. Untreated, on the other hand, is 85%. And we know that those folks that have advanced fibrosis and cirrhosis do have potential for worse outcomes. So HCC surveillance, as we discussed, should again be considered with an ultrasound at AFP. In those folks who have a suboptimal ultrasound or there are issues with evaluating by ultrasound, CT or MRI can be considered. Variceal screening should also be considered in those that have cirrhosis. DEXA scan should be monitored periodically. These patients are at risk of osteopenia, osteoporosis. Thyroid function should be monitored annually. And it's important to monitor for disease progression. Now, typically, ursodeoxycholic acid is indicated here as a standard first-line treatment at 13 to 15 mg per kg per day, which has been shown to improve transplant-free survival, with the 10-year survival being about 80%, and as opposed to untreated being about 60%. This is pretty safe and well tolerated. There are some patients that can have mild GI upset or weight gain or even hair thinning. Treatment response has been conventionally assessed at 12 months, typically with alk phos reduction or normalization below 1.67 times the upper limit of normal. But about 20 to 40% of patients will have an incomplete response where second-line therapy should be considered. And I think more recently, the hepatology community has been looking at emerging considerations to look at treatment response at 6 months rather than at 12 months in order to prevent further risk of progressive liver disease. So there are 2 approved agents from the FDA for second-line therapy for PBC in 2024, both seladelpar and elafibranor. And these are supposed to be used in combination with ursodeoxycholic acid, or they can be used as a monotherapy if patients are ursodeoxycholic acid intolerant. Now, obeticholic acid was voluntarily withdrawn from the US market due to safety concerns. Off-label fibrates such as bezafibrate, fenofibrate may improve alk phos and pruritus, but these are not FDA approved. And with the advent of having FDA-approved second-line agents, I think most hepatologists are moving towards using the approved second-line therapies rather than using fibrates now. So this is just to highlight the NEJM study, phase 3 trial of seladelpar, showing that there was a biochemical response on the right-hand side of 61.7% as opposed to 20% in the placebo group. Then alk phos normalization in 25% versus 0 in the placebo group. So that is pretty impressive. Okay, moving on here to elafibranor and primary biliary cholangitis. So this also showed that their biochemical response had a significant differential of 51% as opposed to 4% in placebo on the left-hand side, and the normalization of alk phos in 15% versus 0 in placebo. So again, both of these, both seladelpar and elafibranor, have very good data to suggest improvements in alk phos and improvements in biochemical response. Now let's talk about cirrhosis for a moment. We know that cirrhosis has a median survival of 9 to 12 years once compensated. In those that are decompensated, the median survival goes down to about 1.8 years, so 1 to 2 years. These patients are at risk of decompensation. And it's important to recognize that there's now non-invasive assessments to look for portal hypertension using elastography and platelet counts that typically over 25 kilopascals for liver stiffness measurement would indicate clinically significant portal hypertension. On the other hand, if it's between 20 to 25 with a platelet count threshold of less than 150 or 15 to 20 with a platelet count threshold of less than 110, those would also be at high risk of clinically significant portal hypertension. And the reason why that matters is because we know that non-selective beta blockers, there's a new paradigm in terms of preventing death and decompensation, that in the Pradeshi trial, the risk of any decompensation was reduced to 16% in the non-selective beta blocker group, as opposed to 27% in placebo. Further, when we look at carvedilol and the reduction of decompensation and death, this was a meta-analysis of individual patient data showing that there was a reduction in death and decompensation using carvedilol. So carvedilol has become a preferred agent as compared to propranolol and nadolol. And looking at carvedilol versus traditional non-selective beta blockade in the systematic review of 810 patients, there was a increased HVPG reduction of nearly 2 millimeters of mercury and nearly 8% with carvedilol. no difference in hemorrhage or mortality in the study, but an improved HVPG reduction, which is important to potentially reduce the risk of future adverse outcomes. Now, briefly speaking about liver cancer, this is the sixth cancer most common globally, the third leading cancer cause death globally in the United States, and higher predominance in males rather than females. 80% of patients here have cirrhosis that develop HCC, the annual risk being about 1.5 to 2%. Viral hepatitis-related HCC has plateaued in the United States and most of the developed world. However, rising cases of both alcohol-associated and MASLD-associated HCC is becoming more prevalent. And so when we talk about HCC, you can see on the global map here that there's a pretty wide distribution, and also in terms of etiologies of disease. And it's important to consider targeted surveillance in those patients that have cirrhosis with, again, an ultrasound and alpha-fetoprotein every 6 months. In those that have chronic hepatitis B, those are also patients at risk for HCC. So men from endemic countries that have an age over 40, women from endemic countries that have an age over 50, persons from Africa at an earlier age, those are the family history of HCC. Those patients all should undergo targeted surveillance as well. Right now, we do know that there is an increased risk of HCC in those patients that have MASLD, even that are non-cirrhotic. However, the guidance statements as of right now do determine that those patients are insufficient risk for screening, that there's not enough data, and so that they need more risk stratification models for both non-cirrhotic MASLD and also Hep C with stage 3 fibrosis. Surveillance for Hep C with stage 3 fibrosis, I would say in the hepatology community is somewhat a little bit individualized and provider dependent, but by formal guidelines is not recommended. So primarily for cirrhosis in those patients with chronic hepatitis B that have special population risk, as discussed here. And in terms of HCC criteria for transplant, we're looking primarily at the Milan criteria, which is 1 tumor less than 5 centimeters or 3 tumors less than 3 centimeters without extrahepatic spread, without macrovascular invasion, having a 4-year survival of 75% and a recurrence-free survival of 83%. So for those patients that are outside of the Milan criteria, it can be down stage 2 Milan criteria, or if they're within Milan criteria, they can be referred for transplantation. Often this is done in combination with a bridge therapy with liver-directed therapy. So for liver transplantation, we know that the median survival is 10 years and higher. 5-year recurrence rates of liver cancer can be up to 10% even after transplantation for recurrence of HCC. However, it's much higher in those that do not undergo transplantation. There's also a UNOS downstaging criteria, which I will not get into great detail here. And for those patients that have an AFP over 1,000 at baseline, they typically need to improve to 500 or below in order to get a MELD exception. MELD exception typically requires a 6-month waiting period in order for patients to get a median MELD at transplant -3. Then, won't go through this in great detail, but just to look at the Barcelona liver cancer staging criteria, really to say that if patients have early stage tumors, to see if they're potential transplants for potential candidates for liver transplantation, and if not, to consider ablation. But if they are potential candidates for transplant, if they have an elevated portal pressure, signs of essentially clinically significant portal hypertension, those patients should not undergo resection and usually should be considered for transplantation. On the other hand, if those patients have normal portal pressure, resection can be considered in some cases. Ablation can also be considered, which I think much more commonly nowadays, liver-directed therapy with ablation is being done as opposed to resection, but resection is important to consider in some cases. For those patients, on the other hand, that have portal hypertension, they should be considered for transplantation. For those patients that have intermediate stage with multinodular disease, those patients can be considered for liver-directed therapy with TACE or potentially even radioembolization. And those that have advanced stage disease with portal vein invasion, extrahepatic spread are often considered for systemic therapy, immunotherapy being the first line with atezolizumab, bevacizumab, or durvalumab, tremelimumab. And there are also second line and third line therapies there as well. So this is kind of just to go through the last slide, but essentially to show you where we've come in terms of systemic therapy, that when we had sorafenib versus placebo, the median overall survival was 11 versus 8 months. And we've come such a long way now that if we look at the standard of care, which is for immunotherapy, telazizumab and bevacizumab, we're seeing median overall survival of 19 versus 13 months, or in durvalumab versus tremelimumab in the Himalaya trial of median overall survival of 16 versus 14 months. So we've come a great long way. In terms of patients with immunotherapy being downstage to transplantation, it's still something that is being considered. There is some exception guidelines that if patients have had a ruptured HCC or portal vein invasion and they have a excellent response to immunotherapy, that it may be considered in some settings. But I think largely if you've had extrahepatic spread and metastasis from HCC, then I think immunotherapy downstaging to transplantation is not really universally being done at this point, not universally being considered at this point. And so I think this requires more study in terms of, recognizing what is the role of immunotherapy as a bridge mechanism for transplantation. But that is the end of my talk. So thank you all for being here and listening to it.